So good morning, dear friends and respected faculty. It's 9 o'clock, we start. We welcome all the esteemed faculty and the delegates, and we have Dr. Pankaj Garg, President IP Delhi with us. I request him to please introduce chairperson for the day, Dr. Divyang Patel and Dr. Vineet Tyagi.
Right. So good morning, friends. I welcome you all on the Master E classes in Pediatric Rheumatology. IEP Delhi's initiative of educating or improving the background academic skills of all the pediatricians all over India. We have done it last years also in field of pediatric endocrinology and neonatology and hematology. So this year we are doing it rheumatology. This is the fifth session which is being presented today, and I have the pleasant duty of introducing Dr. Divyang Patel. Dr. Divyang Patel is currently consultant pediatrician in Vardhan Hospital, Modasa, Gujarat. He is EB member of Central IAP to 2025. He has been EB member of AOP Gujarat 19, 20, 21, 22 and 24. President of AOP Sabaknath branch from 19 to 24 and President of IMA Modasa 19 to 22. His major achievements is National Coordinator Gut Health Module, West Zone Coordinator DS Module, Trainer Basic Advanced NRP, Saksham Impact. So I welcome you, Dr. Divyang Patel, to this platform, and I'll request you to introduce the speaker for the day, Dr. PRATAP.
Good morning, dear friends, and thank you very much, IIP Delhi, for giving me opportunity to chair the session. Thank you very much, Dr. Ajay Kumar Gupta, Dr. Pankaj Garg, sir. Today we have a very tricky subject, systemic lupus erythematous. Basically, pediatric rheumatology is somewhat mystery bag for all of us, and I'm thankful to IIP Delhi for taking initiative to making these subjects very clear and easy. Today we have a Dr. Pratap Kumar Patra as a speaker. He is a consultant at All India Institute of Medical Science, Patna, and he has done his DM in rheumatology from JIPMER Chandigarh. And presently, he's an additional professor of pediatrics at AIIMS Patna, and he has more than 70 publications of pediatric rheumatology in various international as well as in national journal. And I hope this session will be lucid and informative for all of us. So without wasting much time, I am giving stage to Dr. Pratap Kumar Patra for today's session. Dr. Pratap Kumar Patra, sir.
We also welcome Dr. Shyam Meena, sir, Secretary IP Delhi. I request him to say a few words.
You are muted, Shyam. You are on muted.
Hello, very good morning to all. The chairperson, Dr. Divyang. And Pratap, I think you remember me. We are the just together in the PGI. When I entered for the DM, just Pratap is in final year in rheumatology.
Yes, sir. Yes, sir.
So we have a great journey there. पुराने दिन
Yes,
याद
sir.
आ गए होंगे भाई.
हाँ जी sir. Yes, sir. Sure, sir.
चलो. Thanks to our program designer and coordinator, Dr. Ajay Gupta and Dr. Annu Maheshwari. They nicely scheduled and planned this very informative program. And definitely pediatric rheumatology, one of the neglected part, even from the pediatricians. So that is by this class, definitely all private practitioners as well as all residents get the benefit. Over to Dr. Ajay.
Thank you, Dr. Meena. Our other chairperson is Dr. Vineet Tyagi. He is executive board member from UP. He'll be joining shortly.
Okay.
Then I request Dr. Patra sir to please start sharing his screen and start the presentation.
My slides are visible.
Yes.
Yes, sir.
Am I audible, sir?
Yes, yes.
So
Go
thank you, Chairperson, for the kind introductions. I thank Delhi IP for giving this opportunity for presentations on SLE. SLE is a very complex disease of the childhood, and management is quite challenging. And so without wasting much time, I'll go ahead with the presentations. So learning objective of the today's talk is we'll discuss about history of SLE. We'll discuss some case dignity. We'll discuss the recent classification of systemic lupus erythematosus and what are the investigations that one need to carry out before diagnosing a patient of SLE, and how do we manage SLE. So looking back to the history, the lupus term has been derived from the Latin word, and its meaning is wolf. The SLE was first described by an Italian monk and a surgeon named Roselius Frugadi in the 13th century because it reminded them the facial lesion of a wolf. Then, much later, after 500 years, in 1833, he was a French dermatologist named Pierre Cazenave. He added the term erythematosus to lupus because of the description of the rash that was red in color. Subsequently, it was Van Hebra and Maurice Kaposi in 1856 described about the systemic nature of the disease or about the internal organ involvement of the disease in lupus. Sir William Osler in 1903 also described about the internal organ involvement in the SLEs. He also added another manifestation of the disease that was exudative erythema, which we know as vasculitis. It was Malcolm Hargreaves, a pathologist in the Mayo Clinic, first discovered the LE cells in 1946. And subsequently, many antibodies were discovered in SLE. This led to the development of the other specific antibody test and diagnosis of the lupus. One of the examples is anti-Smith antibody, and it was named after a patient called Smith, and it was described by Deicher, Holman, and Kunker in 1956. So this was the little bit history about the lupus. So what is lupus? The SLE term has three words: systemic, lupus, and erythematosus. Systemic means systemic manifestations are common. Multi-system involvement of is quite common, and lupus is the Latin word because that reminded of wolf, and the facial features of lupus patients resemble the wolf, and erythematosus because their rashes are red in color. So SLE is a multi-system disease. Unlike other conditions in pediatric rheumatology like JIA, it does not kill, but systemic lupus erythematosus can kill a patient if not managed in proper time. This is a disease characterized by autoantibody productions, and finally immune complex mediated damage is occurred with the various organs. In 15 to 20% cases of lupus are diagnosed before the age of 16 years. So it's a disease where females are more commonly affected, especially in adolescence and adulthood, where the prevalence is quite common with female to male ratio of 9:1 or 10:1. Certain ethnicities are at risk of developing of SLE. Those are Hispanic, Asians, and Black people are at risk of SLE. If we look at the global prevalence of SLE, the prevalence of SLE varies from different geographical area, and the prevalence of 3.2 to 3,000 per 1 lakh population has been documented, and the incidence of 1.4 to 8.7 per 1 lakh person has been illustrated. So next we'll discuss about a case. So this was a 9-year-old girl. She presented with fever and rash for 1 month. She also had this type of discommutative lesions over the palm and the soles. So these are the lesions she had when she presented to us. And additional to that, she had frontal alopecia and she had malar rash that was prominent over the cheek. This child also had this type of rounded lesion over the back, over the trunk, and over the extremities as well as. There was no history of any drug exposure in the recent past, but there was history of photosensitivity facial rash, alopecia, there was painless oral ulcer, and she used to complain fatigability. On investigations, serology for mycoplasma, HIV, hepatitis B, and hepatitis C was negative. So also the serology for herpes virus was also negative. On further investigations, C3 and C4 was found to be very low. The indirect immunofluorescence showed 3 plus positivity and was 3 plus in this spiral pattern. The anti-dsDNA and anti-phospholipid antibodies, however, were negative. The skin biopsy from the dermo-epidermal junction was positive for IgG, IgM, IgA, and C3 on direct immunofluorescence examinations. APLA was negative, and urine for albumin was negative. So she was diagnosed as a case of lupus with erythema multiforme-like lesions, and she was initiated on intravenous first dose of methylprednisolone that was given for 5 days. Subsequently, the dose of prednisolone was tapered, and she was noted to have significant improvement after 1 week of therapy. So this was the case of lupus where erythema multiforme-like lesions were noted. So the cutaneous lesions is quite common features in SLE and the presenting manifestations. So what are the acute cutaneous lupus lesions that are very characteristic? So in lupus, you'll get this type of malar rash that will involve the nasal breeze, and especially it will spare the nasolabial form. This is very characteristic of SLE. Apart from this, discoid lesions are quite common in SLE, and discoid lesions are more commonly seen over the pinna, and it is behind the pinna. At times, scalp is also affected that result in alopecia. Apart from this, in mucocutaneous lesions are very common in SLE, and if you examine the mouth, this type of erythematous lesions will be seen over the hard palate, and this type of vasculitic lesions over the extremity can be seen. You can also come across annular erythematous-like lesion over the trunk, and this in SLE sometimes the chilblain lupus, also called chilblain lupus, this type of erythematous lesions along with gangrene can be seen in SLE. So what is the SLE etiophysiology? So SLE is the conditions where both innate susceptibility, autoimmunity plays a important role, and environmental stimuli like drugs, UV exposure, especially UV sunlight, that is UVB, plays a very vital role in the evolution of SLE. Microbial infections like Epstein-Barr has been implicated in the occurrence of SLE. Drugs, most commonly antitubercular drugs and anticonvulsant drug, antipsychotic drugs, antihypertensive medications, all have been implicated in the pathogenesis of SLE. So this is the cartoon depicting the pathogenesis of SLE. So in genetically predisposed individual, especially female gender, are at risk of development of SLE because of female, there is estrogen, and estrogen increase the antigen presentations, and there will be formation of the autoantibody. In SLE, what happened? There is defective apoptosis. Then when there is defective apoptosis, all the cells when degraded, they are exposed to the antigen presenting cells, like professional antigen presenting cells are the myeloid cell and interactive cell. They present the antigens to the T cells. T cells secrete the interferon, and T cell also stimulate the B cells. B cells produce the antibody, and this antigen and antibody complex, along with the C3 and C4, they mediate the organ they miss, and the B cell activations and these plasma cell which further are long-lived in SLE, responsible for continuous antibody productions. The SLE classification has revised many times. The first SLE classification criteria was proposed in 1997. According to this classification criteria, one need 4 of the 11 features to diagnose somebody or classify somebody as lupus. And these are the 11 criteria. These are malarial rash, discoid lupus rash, photosensitivity, oral or nasal mucocutaneous lesions, non-invasive arthritis, nephritis, pleuritis, or pericarditis, cytopenia, positive ANA, positive serology like anti-DS DNA, anti-Smith antibody, and anti-phospholipid antibodies. However, this criteria was always specific. It was not that sensitive. Subsequently, this classification criteria was revised in 2012, and it is SLIC criteria. So there were total 17 features. In this, 11 clinical features and 6 immunological features. To classify somebody as lupus, one must have total 4 features with more than 1 clinical feature and at least 1 immunological features, and or there should be biopsy-proven lupus nephritis with anti-DS DNA and ANA positivity. Though SLIC criteria was very sensitive, the specificity was less, and this criteria was revised in 2009. So this is the recent classification criteria that is being followed everywhere, and it was proposed by ULR and SCR jointly. So to classify somebody as having lupus, the ANA has to be present, ANA has to be positive with a titer of 1:80. Apart from this, what they have done many changes. They have added some new points in this, and the fever is the new criteria that has been added, and all these features have been given some weight or given some score. If the patients have been more than 10 points, then can be classified as SLE. In hematological manifestations, leukopenia, score 3, thrombocytopenia, score 4, autoimmune hemolysis, score 4. Similarly, in neuropsychiatric manifestations, they have added delirium to it. They have in mucocutaneous features, they have separated subacute and chronic. And in pericarditis, so serosal feature, they have separated acute pericarditis from the pericardial effusion or the pleural effusions. Similarly, in renal, if there is a biopsy is positive for the class 3 and class 4, they have avoided the highest point score of 10. So these are the classification criteria where you can see the C3 and C4 have been separated and given separate score. And if any patients having more than 10 points can be classified as SLE according to this criteria. However, all these features need not to be present simultaneously in patients, and all these features usually evolve over a time. So this is the difference in the classification criteria of lupus. In SCR, there was requirement of 4 of 11 criteria, and SLIC 4 of 17 criteria, and ULR SCR, one patient has to be ANA positive to classify lupus, and along with the 10 points. So ULR and SCR criteria has sensitivity of 96.1% and specificity of 93.4%. But remember, all these are classification criteria, and this is done for the purpose of a research and for the homogeneity to carry out research, and these are not diagnostic criteria. The diagnosis of SL is still made clinically. So lupus has two phases. Lupus on the outside manifests as joint swelling, malar rash, mouth ulcers. They can present with venous phenomena, discoid lesions, vasculitis, and alopecia. On the contrary, in the inside, they can present with persistent headache, fatigue, memory loss, or depression. The common manifestation of the lupus are mouth ulcers, serositis, there will be pleural effusion, and pericarditis. In kidney involvement, they present with proteinuria or hematuria. In muscle involvement, arthralgia, arthritis, and myositis are common. Similarly, in CNS involvement, seizure and psychosis is most common. In skin, malar rash, discoid lesion, and photosensitivity is the most common presentations. And in blood count, there will be leukopenia, thrombocytopenia, and anemia as well as lymphopenia. And there will be presence of different antibodies. So moving on to the next case. So this was the 8-year-old girl. She presented with photosensitivity facial rash that was associated with progressive alopecia for 6 months. She was diagnosed to have hypothyroidism 4 weeks prior to this illness, and at admission, she was febrile with a pulse rate of 117 per minute. There was mild tachycardia. Other vital were stable, and she was noted to have mild pallor, alopecia, malar rash, painless oral ulcers on the buccal mucosa, and there was abdominal distensions due to the underlying ascites. She also had mild tenderness over the perimeatal area. On investigation, she was noted to have anemia. Total leukocyte count was normal. There was thrombocytopenia and increased ESR. The CRP was normal and DCT was positive. The biochemical evaluation was within the normal limit. On immunological investigations, she was found to have ANA positivity that was 3+, anti-DS2 was positive, the C3 and C4 were markedly low, and antiphospholipid antibodies were negative. On ultrasound, there was a diffuse bowel thickening. So resident on duty at that time thought it can be because of the lupus enteritis. So she was given methylprednisolone 30 mg per kg per day for 3 days, and subsequently she was discharged on oral prednisolone 2 mg per kg, and that was subsequently tapered. She was also put on azathioprine and hydroxychloroquine. However, 3 months after discharge, while the patient on 20 mg of daily prednisolone on SCQ and azathioprine, she presented with abdominal pain, vomiting, and loose stool for 3 days. This time, investigation showed leukocytosis, normal platelet count, both ESR and CRP were high. And the anti-DS2 antibody titer on this occasion was positive. On imaging, abdominal ultrasonography was normal. The blood and stool cultures were non-contributory. So at this time, the possibility of infective gastroenteritis was considered. The patient was put on antimicrobials. She was continued on immunosuppressive therapy. She was put on maintenance intravenous fluid and kept nil oral for 3 days. Her abdominal pain improved after 3 days, but she continued to have intermittent abdominal pain localized to the umbilicus. However, during the hospital stay, she developed sudden bilious vomiting associated with abdominal distensions and bowel sounds were decreased. At this time, the diagnosis of peritonitis secondary to lupus enteritis was considered, and this patient was taken for a recent CCT. On CCT, there was diffuse bowel thickening, and hence the possibility of mesenteric ischemia was considered strongly, and patient was taken for laparotomy on day 7 of hospital admissions. On laparotomy, there was 0.5 ml of contaminated peritoneal fluid was found, and 2 gangrenous segments measuring 40 centimeters each in the duodenum and ileum was found. So there was resection was carried out for this, and this patient was that in this patient was in the pediatric surgery intensive care unit following post-operative period. However, during post-operative period, she developed septic shock due to Klebsiella pneumoniae and died on day 20 of hospital stay. So, message from this case is abdominal pain in patients with lupus can be because of the underlying mesenteric vasculitis, which is a very life-threatening conditions. The case of mesenteric vasculitis in the second admission was faced because of the ultrasound abdomen was normal. So the GI manifestations in lupus, apart from this, can be presented with mouth ulcer, dysphagia, anorexia, nausea, vomiting, hemorrhage, and abdominal pain. And at times, the severe condition like mesenteric vasculitis. Moving on to the next case, this was a 3-year-old boy. He was born out of non-consanguineous marriage. He presented to us with history of persistent skin ulcerations. So these are the type of skin ulcers you can see over the soles and over the palm. He also had painless oral ulcers, photosensitive marrow rash, and additionally, he used to have recurrent ear discharge. On investigation, there was anemia. The total white cell count was normal with neutrophilic predominance. ESR and CRP were elevated. The serum complements, however, found to be normal. ANA was positive with the spectral pattern with anti-DSDNA was negative. He also had nephrotic range proteinuria and it was 64 mg per liter square per hour. For that, kidney biopsy was carried out and it revealed class 4 glomerulonephritis with Woodhouse pattern. The classification ULR and SAR score was 18 for this patient, and with a diagnosis of lupus, early onset lupus, because this was a 3-year-old boy, he was managed with first dose of intravenous prednisolone, and subsequently he was put on heparin dose of oral prednisolone. He was continued with hydroxychloroquine, and for nephrotic syndrome, high dose mycophenolate mofetil was initiated. His cutaneous ulcerations improved after the treatment, while other manifestations did not respond. That's why with the diagnosis of monogenic lupus, because the early onset lupus, genetic test was carried out. In genetic evaluations, there was a novel homozygous deletions in this C1q gene. And this because there was a C1q deficiency and there was no availability of stem cell transplant at our center. We start regular plasma transfusion for these patients every 3 weekly, and the patient is doing well now in the follow-up. So this patient had, apart from the cutaneous features, had nephrotic syndromes. So lupus nephritis is seen in 20 to 60% patients with lupus, and it is one of the leading cause of mortality and morbidity in children with lupus. So what are the indications for kidney biopsy in lupus nephritis in children with lupus? So there is no clear-cut evidence-based guidelines. The clear indications are when a patient is present with nephrotic syndrome, when there is acute nephritic features, and there is persistent elevation of creatinine, then one should consider biopsy. And there is controversy regarding whether in mild or asymptomatic hematuria or proteinuria cases, the biopsy should be carried out or not. It's really that's matter of debate. So what are the presenting features of lupus nephritis? In lupus, most commonly, they present with microscopic hematuria with 79% of patients. Nephrotic syndrome is quite common. They can also have isolated proteinuria. Apart from this, these patients can present with hypertension, reduced GFR, and at times, acute kidney injury can be a manifestation of lupus nephritis. The lupus nephritis is classified into 6 categories. Out of these, the class 3 and class 4 is the most dangerous subtype of lupus nephritis. If it is not detected on time and treatment is not initiated at proper time, then end-stage renal disease is invariably going to occur. So this is the International Society of Nephrology, Renal Pathology Society classification of lupus, and class 3 further they have classified into whether active lesions are present or whether there is a mixture of active and chronic lesions or only chronic lesions are present. And this is the activity index and the chronicity index, whether cellular proliferation is present or not, whether there is cellular quiescent is present or not. So histopathology, people will give this report and what is the activity and what is the chronicity. This classification criteria has been recently modified in 2019 because there are some issues in this classification. However, this recent classification is yet to be adopted by the pathologists worldwide. So what is the treatment of lupus nephritis? Like malignancy treatment or leukemia patient treatment, there is two phases, induction phase and maintenance phase. So similarly, patient with lupus nephritis has to be treated in two phases. In induction phase, the most common drugs that are useful for the treatment are the cyclophosphamide and mycophenolate mofetil. And maintenance phase, usually we prefer to use mycophenolate mofetil or azathioprine also can be used. So this is the recent guideline that has been provided by the ULR, ERA and European Dialysis and Transplant Association recommendations that is published in Annals of the Rheumatology. So the initial treatment in all patients of lupus nephritis should be started with hydroxychloroquine, and initially IV prednisolone dose, the 30 mg per kg has to be given. Subsequently, the dose of prednisolone should be tapered as quick as possible to less than 5 mg per day. And for initial treatment, mycophenolate mofetil at high dose, 1200 mg per meter square can be initiated, and subsequently the patients should be kept on maintenance with the MMF only. And if we consider inductions with low dose cyclophosphamide dose is 500 mg per meter square, and subsequently maintenance can be done with MMF or azathioprine. If you initiate the treatment with low dose cyclophosphamide and plan to give meloxicam, then one should always combine with two drugs, either epinephrine with belimumab or low dose cyclophosphamide with belimumab. And in maintenance also, MMF and azathioprine should be continued along with belimumab. Those patients do not respond to above measures, we can combine two drugs, MMF and cyclo, and we can combine with voclosporin and tacrolimus. And those patients, if not respond, one can use high dose of cyclophosphamide, that is 750 mg per meter square. Apart from that, if any of the measures fail to achieve desired response, then rituximab can be used. So this is the guideline that has been proposed for the treatment of lupus nephritis in adults. In pediatrics, there is no randomized control trial, and all the treatment in children has been obtained or extrapolated from the adult data. So once you start the treatment for lupus nephritis, so what should be the goal? The target is 25% reduction in the proteinuria at 3 months, 50% reduction in proteinuria at 6 months, and at 1 year to 2 years, the target should be less than 0.5 or less than 0.7 gram of proteinuria. Apart from this, the adjunctive treatment that should be given in patients with lupus nephritis is your SC inhibitors. So moving on to the next case, discussed about the mucocutaneous features lupus. We discussed about the lupus nephritis. We will discuss about the next case. This was a 13-year female child. She was resident of Sitamarhi, Bihar. She presented with fever for 6 weeks and had one episode of seizure that was generalized tonic seizure, and she was being treated as encephalitis outside. However, there was no response. On investigation, she was found to be anemic. There was lymphopenia, there was thrombocytopenia, ESR was high, and CRP was normal. The urine examination was normal, and CSF examination was also found to be normal. So on neuroimaging, this is the bilateral hyperintensities were noted over the basal ganglia regions. The ANA you can see here showed the homogeneous pattern, and it was strongly positive. It was 4+, and along with these, other antibodies like anti-dsDNA, anti-liposomal antibodies, and anti-Smith body was also present in this child. So the diagnosis of CNS lupus was made in these patients. So for that, she received injection cyclophosphamide 500 mg per meter square for 6 doses. Initially, she received injection methylprednisolone for 3 pulses. Subsequently, the dose of prednisolone was tapered, and she was also given SCQ 200 mg once daily along with calcium. She was advised photoprotections and sun protective measure, and sunscreen lotion was advised with SPF more than 30. So the CNS manifestations in lupus has many phases, and they can present with peripheral manifestations or central manifestations. The central manifestations are most commonly headache. They can present with demyelinating syndrome. They can present with seizure, acute convulsional state. Manic depressions, mood disorder are also common. They can have anxiety and cognitive dysfunction. They can have depression and psychosis. The peripheral manifestations are the AIDP-like presentation. They can present with Guillain-Barré syndrome, autonomic disorders. They can present with mononeuropathy and myasthenia gravis, and cranial neuropathy and plexopathy and polyneuropathy. So what should the treatment approach in patient with CNS lupus? First, we have to confirm the diagnosis and determine if they are attributable to SLE or it is because of the other causes like hypertension, infections, or any metabolic abnormality. So one need to do a CSF examinations, one need to do electrophysiological studies and psychological assessment and neuroimaging of the brain. So what are the symptomatic therapy that should be given in a patient? Obviously, the patient showing seizure, anticonvulsant is given, and antidepressant antipsychotic therapy is given if all these features are present. And SLE-specific therapy are corticosteroids, cyclophosphamide, MMF. And if a patient is resistant to all of these therapies, then rituximab can be given. Apart from that, if antiphospholipid antibodies are present, then we have to give antiplatelet therapy or heparin or oral anticoagulants like warfarin. So what's the general laboratory investigation that is commonly carried out in lupus patients? It's in the common investigations as CBC, SSCRP, and ferritin. One has to look for proteinuria proactively. Apart from this, ANA and anti-dsDNA antibodies are routinely carried out. One need to check complements, thyroid functions, because thyroiditis is quite commonly associated with lupus, and antiphospholipid antibodies, because when there is presence of antiphospholipid antibodies, the chance of thrombosis increases, and one need to give antithrombotic prophylaxis in these patients. So what's the general treatment guideline in the SLE? So in any patient, one need to assess which organs are involved, and one need to assess the disease activity also, and one need to also recognize the flare that occurs because of the infection in these patients, and one need to detect the infections. We need to counsel and educate the parents regarding the severity of the conditions, because once SLE diagnosis is made, it's a lifelong disease. There is no cure, and only supportive treatment is available. And one need to advise sun protections. SPF, the sun protection factor with more than 30 should be advised, and vitamin and D, calcium, and vaccinations like influenza vaccine and pneumococcal vaccine should be advised before the initiation of the treatment. Also, based on the severity of the organ involvement, if there is skin, mucosa, musculoskeletal manifestations there, when there is serositis, cytopenia, fatigue is there, then one can use low-dose corticosteroid, hydroxychloroquine, and chloroquine and methotrexate. Whereas there is renal involvement is there, CNS involvement is there, when there is severe cytopenia, liver involvement is there, then the treatment regimen is different, or in this situation, one needs to use high-dose corticosteroid along with steroid-sparing agents like MMAT and azathioprine. So this is the treatment guideline for the non-renal lupus. Okay, so it depends on the severity of the involvement, and SCQ should be given to the all patients, and glucocorticoid also one the important component of therapy in lupus. One cannot treat lupus without glucocorticoid. That should remember. And methotrexate, azathioprine, and MMF are also used in all situations, and belimumab can be also used, and anifrolumab is another interferon receptor blocker. However, this is not available in India. One can use calcineurin inhibitor like tacrolimus, cyclophosphamide in severe cases, and rituximab in very severe cases. So target in these cases of lupus is to take for the remissions, one need to routinely do this SLEDAI score, and the target should be glucocorticoid doses less than 5 mg per kg, or when the remission is could not be achieved, one should target the low disease activity with SLEDAI score less than 4 with a target of continuous SCQ and glucocorticoid less than 5 mg per day. So in every time a patient visits to us, we need to check the SLEDAI score or disease activity score. So this is the SLEDAI score chart, and it has 24 items, total 24 items, and it is hardly take 2 to 3 minutes to complete this SLEDAI scoring, and the score ranges from 0 to 105. A high score indicates increased disease activity, and what one should target at least the score should be less than 4. So my take-home message in today's class is that children with lupus require a multidisciplinary approach. Glucocorticoids and SCQ are the mainstay of therapy. Disease-modifying antibiotic drugs like methotrexate and azathioprine are recommended when there is persistence of symptoms. Non-live vaccines, especially influenza and pneumococcal vaccines, are recommended before the initiation of therapy. One need to encourage sun protections, liberal use of sunscreen lotions with a sun protection factor more than 30. One need to ensure blood pressure is normal, patients receive adequate nutrition, and support of the mental health is required because it's a long disease. Then one has to regularly assess the disease activity on follow-up using the SLEDAI score for the monitoring of the drug side effects. That is crucial. So thank you for your kind attention.
Thank you, Dr. Patra, for a wonderful presentation. Once again, we welcome, please stop sharing the screen. Once again, we welcome Dr. Vineet Tyagi as chairperson. I request him to please say a few words.
Thank you, Dr. Ajay, for the welcome. Very nice presentation by Dr. Patra. Made a very complicated issue in a very simple and lucid fashion. Dr. Patra, how frequently do you feel that a pediatrician come across a case of SLE in his practice? Because I think that sensitization towards SLE is more important. As a general pediatrician, we tend to miss the early signs of SLE, and usually when they land up in complications like pericarditis, nephritis, later on investigations, it turns out that the case was of SLE.
So SLE is quite common. You will come across in your OPD practices, and these patients' early features is the malar rash. Malar rash is quite common. Arthralgia is quite common. Whenever you examine a patient who has multi-system involvement, okay, more than one organ involvement, likely to have autoimmune diseases. That one should remember, sir. And when there is symptoms is chronic in nature, one should always think of multi-system connective tissue disorders. So it is the chronicity and presence of multi-system nature of the disease. So one should always think of autoimmune conditions. These patients are mostly comes to you during the adolescent or adulthood period, and the presentation of lupus is less common in early years. Later,
This is breaking. Thank you, Dr. Patra. Actually, this is what I wanted to highlight, that pediatricians in general tend to focus more on the mucocutaneous lesion only, but SLE can present with just with arthralgia or arthritis, and sometimes mucocutaneous lesion may be difficult to pick up in OPD practice because of the inherent color of our Thank you,
yes, sir,
Dr. Patra.
fully agree, sir.
Thank you, Dr.
Fully
Vineet.
agree, sir.
Dr. Divyang, your comments, please.
Very nice and lucid presentation. Started from the wolf and going to the latest treatment. So it's complete cover the SLE. And yes, Vineet Bhai has to point out very well that we should diagnose the patient early, because our aim is to diagnose the patient and send them to rheumatologist, because later complications are fatal. So prevention is always better than cure. So sensitization of pediatricians are very important in this type of cases. So it was really helpful to all the pediatricians who have attended this. So if any questions from the audience, we welcome that.
Dr. Divyang, there's a question from Dr. Manish. What is the total duration of therapy for new onset SLE once remission is achieved? Dr. Patra?
Sir, the treatment is lifelong. The treatment is lifelong. There is no cure. The goal should be maintain these patients once remission is achieved. Low patients can be managed with 5 mg per day. This is quite low dose, and this is given for lifelong till we transit them to adulthood. Okay, so adult rheumatologists take over. So, and most important is to maintain the sun protection. Sun protection advice is most important, because sun is the enemy of patients with lupus. So sun protections, and another important is your bone health, checking of bone health, and one need to advise vitamin D and calcium very liberal to these patients. So lifelong treatment is required once you achieve remission, especially in non-renal lupus. If there is renal involvement, once remission is achieved, duration of therapy for maintenance, but we use MMF and azathioprine, it is up to 5 years. Longer the duration of the treatment, better the outcome in lupus nephritis.
Thank you, sir. And Dr. Bannard wants to ask some questions. Dr. Bannard, please. Please unmute.
Dr. Bani, sir, you can directly ask.
Excellent and lucid presentation. It is very interesting to hear. See, my doubt is regarding the PUO cases, because I have seen a PUO with SLE. So suppose a case of PUO we see, and when we should think of the possibility of SLE, and when we should start investigating by thinking that can be an SLE. So what time?
Yes, sir. So PO can be because of many causes. Either it is inflammatory, or it can be malignancy, or It can be because of the infections, chronic infections. So inflammatory cause, typically when you think, so especially girl child in the adolescent age period, and you have to do some common investigations, CBC. So CBC will give the clue. CBC and ESR with CRP will give the clue. So if your CBC is showing anemia, the platelet count is towards lower side. If the ESR is high and CRP is normal, because it's an interferonopathy, CRP is suppressed, so your ESR will be high, CRP will be normal. Or if all these are subtle features and the patient is having chronic fever, then possibility of lupus always should be explored.
So practically speaking, ESR will be high and CRP will be normal or low. That will be the
point. That is a pointer towards a chronic inflammatory state. Okay. So that can be lupus.
Okay. One more doubt is, suppose some mild cases are there, and you don't feel like giving methyl prednisolone. Is it okay to give start with this normal prednisolone? Or
it is always right. We start with oral prednisolone. 200 kg you can give if you want to give high dose. And subsequently, after 4 weeks, after doing the complements, after looking at the ESR, ESR is the most common inflammatory markers.
Please be near the mic, sir. Please be near the mic.
Yeah, it's not very clear then.
Yes, sir. So you can give oral prednisolone. And one should remember the cornerstone of lupus therapies, SEQ and glucocorticoids. These are the two important milestones of treatment of lupus. So HC, the steroid can be started, and you give, sir, SEQ, especially patient while going to sleep, should be given an OD dose, and the dose of SCQ should be less than 5 mg per kg, because you know it is going to have retinal toxicity as complications, especially when patients are put on long-term therapy. So one eye examination should be carried out before starting SCQ.
So how long you are supposed to give? Can be stop at any place, or you have to continue like a very low dose?
In lupus patient, only few patients in our cohort we have been able to stop steroid, and many patients are on SCQ. They're lifelong. It's lifelong treatment, sir.
Okay. Thank you.
So there is one more question by Dr. Rizwan. What is the reproductive outcome in adolescent girl?
Sir, I don't have any experience regarding the pregnancy in these patients and outcome, because we transit to adult once they become reach that state. Once they become more than 18 years, we refer to adult rheumatologist.
Sir, if SLE develops, say, following some medication, can it be transient also?
So the duration of SLE following drug is quite transient. It can persist up to 1 to 2 years. And once the appended drug is taken out, the patient completely improves. Only in these patients, we can use low dose glucocorticoid that is suffice. You can add SCQ also. And these patients' prognosis is very, very good.
See, suppose if you treat the case of with the steroid like oral prednisolone, and you got almost practically that complete cure is there. So how frequent you have to follow up with investigations? Is there any specific criteria?
Sir, actually for lupus there is no cure. We can only control the disease. That we have to explain to the patient. And once the disease is settled down, every 4 monthly follow-up is enough. Every 4 monthly follow-up, once in every 4 months is enough once the patient is stable.
So what are the things you will check during this follow-up? Is it ESR and NA? And
in each follow-up, we look for any drug toxicity is present or not. We advise them regarding the use of sun protections. We advise them to take calcium-rich product. We advise them to take chas, milk, curd, calcium-rich food. We check their vitamin D status. We check their whether the child has received vaccination or not. So these are the common advice that is given to the patient of lupus. Apart from that, we carry out urine examinations, APLA examination every yearly. for because these patients are at very high risk of development of thrombosis. So apply examination every yearly. We look for C4, C3 and C4 3 to 4 monthly. And ESR. ESR will give a clue, sir. If your ESR is normal, then your disease is fairly controlled. No need to do C3 or C4 also.
Thank you, sir. Dr. Anu, our course coordinator, please your comments, please, for today's session.
Sir, I think the presentation was very good. Like Dr. Bennett said, that we started from the history and latest guidelines. I think, sir, lupus is the holy grail of all autoimmune disorders, and Dr. Patra did a wonderful job making it so simple. And sir, one more thing I would like to say here is that a lot of lupus, like in our cohort, we have around 120 patients, in which around 30% of them did not have any skin involvement. So when they were diagnosed, they may not have the skin involvement. That's the message for the pediatricians who are looking for lupus. Skin manifestations, the classic malar rash, may not be present in pediatric age group, and you have to have a very, very high index of suspicion. And especially, these patients may come to anyone, sir. Like I've got referrals from neurology. We get referrals from maybe, patients are having AIHA, or even the children, adolescent girls presenting with ITP. I think it's worthwhile that we investigate them with an ANA, dsDNA, maybe a urine protein, C3, C4, DCT. Dr. Patra, would you like to comment? I think this is the way we should work in the pediatric age group, because the mucocutaneous findings may not be that prominent.
Yes, ma'am. Anupam, I fully agree with your comment. And many patients present with only seizure and neuropsychiatric manifestations. Some children present with stroke. And in our cohort, we have seen nephrotic syndrome is the most common presentations. So they present without any mucocutaneous features. And on kidney biopsy, there will be full pattern of lupus, full house pattern
Absolutely.
lupus.
Absolutely.
Dr. Nilima, you want to ask something? Please unmute. Dr. Nilima. With this, we come to the end of today's session. I request Dr. Shamina, Secretary, IP Delhi, to please give vote of thanks. Please unmute, sir. Please unmute.
Before vote of thanks, I would like to ask some things from the Dr. Patra. What about the vaccination in this child? Because you said that majority of the children require the lifelong immunosuppressive therapy like the steroids. So because most of the cases around the toddler or school going age. So what type of the vaccination would you like to advise before starting the therapy?
Before starting therapy, influenza and pneumococcal vaccines should be advised.
And I request to also advise the hepatitis A vaccination. That is also very important things. Because
Yes.
once you start the immunosuppression, it's very difficult to give the live vaccines.
Yeah, it's very difficult. Yeah.
So at the end of the program, I would like to thanks our chairperson, Dr. Divyang Patel sir, Vinit Tyagi sir. Thanks from the Delhi IEP to spend the time to join us. And Dr. Patra, we really thankful to you. You had such a wonderful, nice presentation. Your presentation covered the whole different various presentation of the SLE. Your case scenario is very informative for definitely our clinician as well as our residents. So definitely thanks for the join us. And I would like to thanks to Dr. Anu, Dr. Dolly, Dr. Neha, and our course coordinator, Dr. Ajay Gupta sir, to plan, schedule, and design this program, because that program is very famous in the all pediatrician or all residents. Because this one is an area definitely neglected among pediatrician. Thank you.
Thank you, Sham.
Thank you, sir.
Over to Pankaj sir.
Thank you all respected faculty and dear delegates. We'll be joining same time 9 o'clock next Sunday. So I request Mr. Sushil, please close the session.
Thank you.
Thank you. Thank you.